Okay. All right. Well, everybody, thanks for joining us today. Today we've got the pleasure of welcoming Dr. Benjamin Hibbert to talk to us about recently published trial, the DoReMi trial, which was published in the New England Journal of Medicine not too long ago. So to introduce Dr. Hibbert, he is an interventional cardiologist and is the director of vascular biology and experimental medicine laboratory at the University of Ottawa. He earned his doctorate in medicine, followed by an internal medicine residency training at the University of Ottawa. Subsequently went on to complete his cardiology training and his PhD in biochemistry at the University of Ottawa Heart Institute. Finally, he completed a fellowship in interventional cardiology with an interest in structural left atrial procedures, again at the University of Ottawa, and completed that in 20. So Dr. Hibbert's clinical interests include both clinical and basic science research projects, the goal of performing translational research. His outcomes-based research has been performed clinically in patients undergoing PCI or structural heart procedures. His topics of interest include biomarker development, adjuvant pharmacotherapy, and the impact of device selection on clinical outcomes. So please, thank you everybody for joining. This should be a really interesting talk. I know there was a lot of buzz about this paper when it was published earlier in the year, and we're very grateful that Dr. Hibbert's taken the time to visit with us today. So Dr. Hibbert, please, the floor is yours.
Excellent. Thank you very much, Dr. Beasley, for the introduction. As Dr. Beasley alluded to today, I'm going to talk to you guys about the DoReMi study. And I'm going to talk to you guys a little bit about some of the work that we do here in Ottawa with residents and research, because that's also a passion of mine. So cardiology and critical care as fields produce large amounts of low quality evidence. So I practice critical care cardiology, I practice interventional cardiology, and a large number of the interventions that I do are based on poorly justified beliefs, and we use these to guide therapy. And we often have to make these decisions in the absence of robust data. Even today, I had a long debate with a neurologist about closure of PFOs in the context of migraines, and we had to conclude that we really didn't know what the right thing to do was. When we look at the evidence pyramid, individual case reports, case series, cohort studies kind of form the foundation, but that really only allows us to develop a hypothesis. We really need RCTs, high quality RCTs, and potentially systematic reviews and meta-analyses of these high quality RCTs to really provide an evidence base and help us narrow the evidence gap, so that when we're meeting with patients and we're discussing therapies, that we're truly doing this based on a solid foundation of evidence. And just because we think we know what we're doing, there's lots of examples in critical care cardiology and cardiology in general where we've been wrong. So when I trained in intensive care, I spent a lot of my nights as a resident carefully adjusting glucoses and doing intensive glucose control. And it wasn't until later that the nice sugar trial demonstrated that the number needed to harm was 33 for death. So a lot of the ICUs that I was a resident in or that I attended in early in my career, we were killing on average one patient every 33 admissions. That's quite a bit of harm for something that made biologic sense, that had a good foundation of observational data. And now the CAST trials predate me, but again, that's another example in cardiology. PVCs were associated with adverse outcomes. We could suppress PVCs with medications, and there was a good foundation of evidence with observational studies that suppressing PVCs might reduce mortality. Of course, as we know now, this increased death rates amongst our patients. Targeted therapeutic hypothermia. Our center just published the Capital Chill trial, and we just published a systematic review meta-analysis in intensive care medicine on this as well. I would have bet big money that therapeutic hypothermia would reduce adverse outcomes in survivors of out-of-hospital cardiac arrest. But as we know now, this has no benefit, and a number needed to harm of 14 for unstable arrhythmias. Even epinephrine in cardiac arrest, number needed to harm of 166 for survival with severe neurological impairment. So I hope I've impressed upon you that we really need good RCT data, and that observational data, our intuition or biologic plausibility, isn't enough to instill therapies for these patients. And unfortunately, the way guidelines are often written is we have to make a recommendation about what to do. And rather than highlighting uncertainty or providing a roadmap for future research, guidelines often make recommendations that have a poor foundation of evidence. And then these these therapies get instilled into practice and then it becomes hard to challenge them with evidence. We need randomized clinical trials. So I don't care how large your data set is, you cannot overcome the power of randomization. There's no propensity matching or statistical gymnastics that you can do that enables you to replicate the power of randomization. And so we really need to be doing randomized trials, even on our most complex patient populations, so that we know that the therapies that we're providing to them provide benefit and not harm. And we need iterative processes that evaluates evidence in the data in the context of advancing technology and care. So trials that were done 30 years ago on very little medical therapy don't necessarily recapitulate the benefits of therapies in the context of modern therapy. I'm an interventional cardiologist, and so I say, revascularization is a great example. Revascularization on a background of no medical therapy is probably more beneficial than on a background of very good medical therapy. And so we need to revisit these therapeutic interventions that we do in the context of less invasive, less costly therapies. So I'm here to talk to you guys today about cardiogenic shock. We all know what the definition of cardiogenic shock is. And it's a very common presentation, both ischemic and non-ischemic, acute and chronic heart disease. And of all the conditions that I treat, this has one of the highest mortalities and morbidities, and it's not uncommon. So when I attend on the CCU, the city of Ottawa is about 1.5 million. We have one heart institute for that catchment area, but we'll often admit 3 to 4 cardiogenic shock patients a week. So this is a very common condition. This is a very common problem that we face as clinicians. And again, it has a very high mortality and morbidity. And so when patients come in, however, with cardiogenic shock, there's not a lot that I can actually offer them that improves prognosis. So randomized trials have looked at revascularization. There's small studies that have looked at the use of vasopressors. There's a paucity of data on the use of inotropes. There's one larger trial at looking at nitric oxide synthase inhibitors. And there's very, very small smattering that look at the use of MCS, including IABPs, percutaneous VADs, and ECLS. But none of those can I look a patient in the eye and tell them that we're really moving the needle in terms of their prognosis. When we look at, these are the guidelines published by Dr. Thiel in EHJ in 2019, and these are for patients that are coming in with cardiogenic shock in the context of acute myocardial infarction. Look at all those B's and C's. There isn't a single class 1A recommendation for these patients. So there's nothing that you can offer these patients that really improves outcomes that you can say with confidence based on good randomized clinical trials. And in fact, when we look at the things that we've studied really well, what we've identified is that in most contexts, we're probably causing more harm than benefit. And so studying cardiogenic shock is incredibly important, but it's something that we do very poorly. So here's a summary of all of the clinical trials that have been done in cardiogenic shock. And what you can see is the shock trial had 302 patients. Triumph had 398, was stopped early due to futility. IABP shock 2 had 600 patients, and that trial was negative. And then culprit shock had 706 patients. And that actually changed our practice from doing multi-vessel PCI to culprit-only PCI, and every other study is less than 100 patients. And when you look at all the prospectively registered trials, there's a lot of trials that have very large sample size, and as we've learned over time, very few of those trials are going to be complete because they're a hard population to study. And what that's resulted in for me as a practitioner, and I'm sure for all of you, is shared frustration. When patients come in sailing the stormy sea of cardiogenic shock, there is nothing that I can look them in the eye and say, I am doing this to improve your survival. We do lots of things to improve their map. We do lots of things to, for lack of a better term, rearrange the deck chairs as the Titanic goes down. But there's nothing that we can honestly say that we're doing for these patients to get them out of hospital. So I'm going to divert a little bit here from the topic at hand to talk about something that I'm particularly proud of, and that's resident and fellow-led research. So here at the Ottawa Heart Institute, we've had now for several years a program where we not only train residents to do research, we integrate them into our research program so that as they're training, they're becoming clinician scientists and researchers. And this has helped us not only to increase our research productivity, but increase the output of residents that we train that go on to become clinician scientists. And we do this by having a competency-based curriculum that's divided into 3 phases. So, and actually we're doing it right now in Ottawa. So our first year cardiology residents are all on their research rotation. And this is constructed of didactic lectures on study design, basic statistical analysis, regulatory framework, and ethic board processes. Next year, they will all get at least 1 more month and up to 6 months, depending on their research interests. And again, this is the time that they do their research projects. And then phase 3, to graduate from our program, they have to have competencies in research, either through publications or presentations. And then for people who are really dedicated to research training, we have a clinician scientist track with clinician investigator program to either get an MSc or a PhD. And we've actually published on this before and shown that we can dramatically increase the number of publications that our fellows get, as well as the number of publications that they get as they go out to early career. And again, we're particularly proud of this program. And these are some of the studies that our trainees have done as residents. So Jason Roberts, who's now at Hamilton, he's an electrophysiologist, published in The Lancet his research project as a fellow, the rapid gene study. Dr. Ronan Mays designed the capital chill trial as a resident. This was published, I think, 2 weeks ago in JAMA. Dr. DeSanto published the iRadial trial in the CMAJ and is currently recruiting for Capital Raptor, which is an 1,800 patient RCT using rivaroxaban after transradial access. And as I'm going to show you guys today, Dr. Rebecca Matthew was a trainee, and her and I did DoReMi together, which we published in the New England Journal of Medicine. And again, just to highlight how integrated trainees are in our research program, and you look at the authors, I've bolded all of the authors who were fellows during their contribution to the trial. So why did we do the DoReMi trial? So this actually stemmed, Rebecca and I were in the CCU. She's just come on staff as a cardiac intensivist here in Ottawa. And we were admitting another patient with cardiogenic shock. And we were deciding which inotrope to start the patient on. And Rebecca said, you know, how do you decide between Milrinone and Dobutamine? And I kind of went on my usual spiel, physiologic differences, rationales, pragmatic reasons, as I was talking about with Dr. Beasley, such as transitioning these patients to the ward. And I said, you know, I'm not really familiar with all of the data in terms of comparative data between Milrinone and Dobutamine. And so we did what we do with all of our projects. We did a systematic review and meta-analysis of both observational and RCT data. And this is shown here. We published this in 2019 in Clinical Investigative Medicine. And you can see there's just not a lot of data. So the only RCT there is 36 patients. Everything else is observational data, although it tended to suggest that there was a reduction in in-hospital mortality with Milrinone. And we looked at a number of secondary outcomes, including arrhythmia, length of stay, duration of therapy on inotrope. And so that brought up the question of whether or not there were important differences between Milrinone and Dobutamine when we're treating patients with cardiogenic shock. And so we decided we were going to set out and do a randomized clinical trial. And we wanted to do it properly. So there was blinding of both physicians and patients. And our hypothesis is that Milrinone reduced the composite outcome compared to Dobutamine. And that composite primary outcome was in-hospital all-cause mortality, resuscitated cardiac arrest, need for transplant or MCS, MI or stroke, and initiation of new initiation of renal replacement therapy. Patients were excluded if they were presenting from an out-of-hospital cardiac arrest. If the treating physician felt that they should be preferentially treated with one or other inotrope, if we couldn't get a substitute decision maker, or if they were participating in another trial. And so over the 3-year period that we enrolled, there were 319 eligible patients evaluated. 127 of those patients were excluded. The most common reason being that they were already on an inotrope by the time they presented to our cardiac intensive care unit. So we're a regional referral center. So a lot of patients come from other hospitals or through the emergency department, and they've already been initiated on inotropes. 40 of those patients, the treating physician, the MRP, and the intensive care unit felt that they should have one or either inotrope preferentially. And again, a small number were out of hospital cardiac arrest, were unable to provide informed consent, were participating in another trial. Ultimately, we enrolled 192 patients in the study and randomized 96 patients to each treatment arm. There was sub-randomization to predominantly left ventricular or right ventricular failure. And again, this was predominantly a trial of left ventricular or biventricular dysfunction in these patients. So who were they? On average, these patients were 70 years old. About a third of the patients were female. Most of the patients in this trial were white, and that reflects the ethnic distribution here in Ottawa. It was a single center trial. Most of the patients had significant left ventricular dysfunction. That's not surprising. So the median enrollment ejection fraction was 25%. In terms of the etiology of their left ventricular dysfunction, again, dominantly ischemic in etiology. And when we look at the SCAI classification of their cardiogenic shock, again, This is predominantly a study of Sky Class C or D shock. So when we looked at the outcomes, the primary composite outcome, there was no significant difference between Milrinone or Dobutamine, with the primary outcome occurring in 49% of patients that were randomized to Milrinone and 54% of patients randomized to Dobutamine. When we looked at pre-specified subgroups in terms of the primary outcome, there was no significant heterogeneity of the outcome, either for sex, the elderly patients, left versus right ventricular dysfunction, although again, very small proportion of patients had isolated right ventricular dysfunction. No difference whether, depending on the severity of baseline of their left ventricular dysfunction, baseline renal function, or concomitant vasopressor use at time of initiation of inotrope. Not surprisingly, all-cause in-hospital mortality was high. This is a cardiogenic shock trial. So about 40% of the patients died. And again, no significant difference was observed between Milrinone or Dobutamine. When we looked at important secondary outcomes, again, no difference in resuscitated cardiac arrest, no difference in initiation of renal replacement therapy. And again, a number of pre-specified important markers of resuscitation. So no difference in the VIS score, which is basically a numeric calculation of how much vasoactive or inotropic support they're on. No difference in urine output, no difference in creatinine, and no difference in lactate clearance. And again, when we looked at heart rate and blood pressure, no difference in either of those outcomes either. So really, it was a wash between Milrinone and Dobutamine in terms of the primary outcome, as well as important secondary outcomes and markers of resuscitation. And so we concluded that in contrast to the hypothesis, we did not identify a significant advantage of Milrinone over Dobutamine in the composite outcome or important secondary outcomes. Again, no difference in important surrogate markers of resuscitation either. And so we concluded that selection of inotropes could reasonably be based on physician comfort and response to therapy. And so, you know, if you're reasonably comfortable using Milrinone because you trained in a Milrinone center, or you're reasonably comfortable using Dobutamine, either or is a reasonable thing to do. And you can see how your patient responds to therapy and then decide whether or not you want to add a second agent or switch to another agent if you're not getting the response that you want. Certainly, there's limitations in the study design. So first of all, only in-hospital outcomes were evaluated, and differences in outcomes may exist beyond the index hospitalization. We've seen this before in a cardiogenic shock trial. So if you look at the shock trial, that trial is negative and took out to 6 months before there were differences between the groups. Now that is an underpowered secondary outcome, and so that might not necessarily be a valid outcome, but there is possibility that there are differences that we could see longer if we looked at longer. Now, again, we saw no differences in important resuscitation markers. So I would be very surprised that we would see those curves start to separate late, but it is a potential. Our study was designed to be pragmatic and replicate clinical practice, in which shock is most often defined clinically rather than hemodynamically. So again, these patients, not all of these patients had Swan-Ganz catheters. And so shock was defined clinically, and that's how we practice. So not every patient in cardiogenic shock gets a Swan-Ganz catheter. I know there's a lot of enthusiasm for looking at the importance of Swan, and there's a lot of observational data that perhaps Swans make differences. I find that hard to believe that Swan-Ganz catheters would make a difference. I understand how getting that data make clinicians feel more comfortable. But again, shock was in this trial defined clinically. And then our power calculation was based on a large treatment effect for a combined outcome. And thus we are underpowered to detect small differences as reflected in the wide confidence interval. So again, there is the potential that there are small but important differences in components of the primary outcome that we were unable to detect. And again, kudos to our 2 trainees. So again, Rebecca Matthew has come on staff as a cardiac intensivist. Pietro actually got accepted to critical care medicine today. So he's completed his cardiology fellowship, is currently completing an interventional fellowship, he's my PhD student in epidemiology, and will be embarking on a 2-year critical care fellowship. So he's going to be extremely well trained when he's done. And they presented this at the AHA Resuscitation Science Symposium, and again, published in the New England Journal of Medicine. And again, I'm excited to share that we have a number of sub-papers coming out of this. So we published shortly after a paper in critical care. One of the things I was taught training is that if patients were on beta blockers, it makes more sense to use Milrinone, and there was some observational data. And so again, we had a randomized cohort. When we looked at that, beta blockers, interestingly, were actually protective in the first 24 to 48 hours in terms of reducing arrhythmia in patients with cardiogenic shock. There's absolutely no difference whether you give patients dobutamine or milrinone in their resuscitative response or hemodynamic parameter. So it doesn't really look, when we're randomizing patients, if a patient's on a beta blocker at baseline, you can, equivalently use milrinone or dobutamine. We looked at MAP targets, so higher patients that can achieve higher MAPs in resuscitation seem to do better. Again, we weren't randomizing to different MAP targets. And so that's an interesting question in cardiogenic shock. What is our MAP target, and could we potentially improve outcomes by targeting higher MAPs? We just published last week a paper looking at myocardial infarction. So again, patients that come in with cardiogenic shock in the context of an MI do worse than patients who are not coming in the context of an MI. There's a theoretical risk of increasing myocardial oxygen demand, specifically with dobutamine. Again, no difference in outcomes in patients with MI that are getting dobutamine or milrinone. And we have a number of other interesting papers, the impact of valvular disease, so that's currently in review, and as well as using lactate clearance as a prognostic marker, that's also in final stages of review, and we hope to have those papers out to you guys shortly. And so this is Shannon Fernando. So he was a critical care fellow. He's actually an emergentologist. And so subsequent to this, we've updated a systematic review and network meta-analysis looking at what therapies do we actually have for patients in cardiogenic shock. So what do we have to offer these patients when they come into our unit? And again, this is because there's a lack of robust evidence in randomized clinical trials to look at how can we improve mortality in these patients. And when we look at these therapies, what we use most contemporarily is vasopressors, inotropes, and MCS, plus or minus revascularization, depending on whether or not they're coming in. We think there's an ischemic etiology. And again, we were unable to do a network for vasopressors because there are no randomized trials of vasopressors, and I could understand how those trials might be difficult to do for these patient populations. However, when we look at inotropes, there are some placebo-controlled randomized clinical trials, and certainly there are different trials with MCS to create a network. And when we look at inotropes, really the only, I hesitate to use the word high quality evidence, but certainly when we use the grade scale, there is some evidence of levosimendan compared to placebo. There was no significant differences between levosimendan and dobutamine or milrinone, and certainly there does not appear to be any benefit of milrinone or dobutamine compared to placebo when we study them in the network. And so again, we're not even certain that inotropes work in cardiogenic shock to improve outcomes. When we look at MCS, we can divide this into IABPs or percutaneous mechanical circulatory support. Again, there doesn't seem to be any benefit of mortality. And certainly we have a very large randomized trial for IABP in patients with acute myocardial infarctions in cardiogenic shock. But importantly, there's no benefit of percutaneous MCS and the small trials that have been done. But there is a significant risk of bleeding. So again, while we're unable to demonstrate any benefit of these technologies, we are very easily able to detect the harm that we're causing in terms of bleeding complications in these patients that come in. And so this paper is currently under review. And again, hopefully we'll have this out very shortly. But based on the current available evidence, there is some evidence to support levosimendan, although the quality of those trials are not great. Dobutamine and milrinone, again, have no proven benefit relative to each other or placebo. And MCS likely increases bleeding, but does not appear to impact mortality. And so where does that leave us? And the reality is I struggle with this. And when I teach the residents, is I don't really know what to do for our patients with cardiogenic shock. We do lots of supportive things. We put them on vasopressors, we give them inotropes, and in select populations, we use mechanical circulatory support, although the foundation of evidence for that is poor at best. And certainly, as I hope I've imparted upon you early in the talk, there's lots of examples in critical care cardiology where we've harmed patients for many years by doing therapies to patients that we believe are beneficial and that are not. And so we will be starting the Capital DoReMi 2 trial shortly. So this is going to be a multi-center trial of inotrope versus placebo in the early resuscitation of stage CD cardiogenic shock. So in the first 12 hours of resuscitation, we're going to randomize patients to inotropes or placebo. And this is to establish the safety and necessity of inotropes in cardiogenic shock. It's interesting when you look at why people die in the first 24 hours in cardiogenic shock, it's either withdrawal of care or often they have cardiac arrest due to arrhythmia. Certainly we know that inotropes can be arrhythmogenic. And while there's undoubtedly some benefits in terms of better perfusion, more rapid lactate clearance, the question is does the increased arrhythmogenicity and the harm that we cause, is that outweighed by the potential benefit of improved perfusion in the short term? And so again, we're very excited to get this trial up because I'm not even sure that we need inotropes routinely in the early resuscitative phase. And secondarily, Dr. Beasley and I were talking about this. And so again, we've just got province-wide approval for this study in Ontario, and we're looking to roll this out both in centers in Canada and the United States, is we're going to look at MitraClip therapy for stage CD shock in patients with greater than 3+ mitral regurgitation. We've been doing, again, there's observational data. So we published a paper in JACC Intervention earlier this year, looking at about 140 patients worldwide that were done. There was another trial published in study EHJ, again, observational data that suggests the observed mortality rates are much lower than we would expect when we intervene on the mitral valve. But again, we need good randomized data. It's a very expensive therapy. It's very resource intensive to mobilize a team to do clips on a semi-urgent basis. And so we're hoping to randomize these patients to ongoing medical therapy versus a MitraClip in our patients with significant mitral regurgitation when they come in. Again, we're super passionate here in Ottawa about studying cardiogenic shock. I hope that I've shown you guys the importance of doing randomized clinical trials. And I hope that you guys agree that we need to randomize our patients so that we get the best evidence base possible, so that when patients come in with cardiogenic shock, we know that the therapies that we're providing to them provide them benefit and not harm. I'd be happy to take any questions and happy to discuss the paper.
Ben, this is Tarek. This was an outstanding presentation, and congratulations on your impressive work that is kind of questioning something that we've struggled with as well. As you know, the Swan-Ganz catheters, there is a randomized controlled trial that shows that they don't really add anything, and clinicians will insist that, well, the patients who actually needed it were never randomized, and the same thing. It's also same thing happened with Optime HF, where if the clinician felt that they didn't need Milrinone, they didn't even get randomized. So how do you kind of get around that, where it's so difficult to change people's minds, where they can just come back and say, well, there wasn't true equipoise because like the clinicians basically took the people who would benefit from the therapy outside of the randomized controlled trial.
Yeah, no, I mean, we struggle with this with everything in cardiovascular medicine. So whenever a trial comes out that doesn't support people's hypothesis, you can always argue that there's a population out there that, benefits from therapy that you've excluded. And so, we have to be, I think, very thoughtful about the therapies that we provide. Even in our trial here, you can see 40 patients of the 300 patients, people were unwilling to randomize because they believed they should either preferentially have Milrinone or preferentially have Dobutamine for whatever reason, even though there's no data. And so all I can say to you is, we all as clinicians need to do a better job about enrolling our patients in clinical trials and, suspending your disbelief about what you think is beneficial. I can't even tell you how many times I've enrolled in clinical trials where I thought I knew the outcome and I've been surprised. We did the Safari STEMI trial here when I was a fellow and a staff, randomizing patients to transradial access in patients with STEMI for a reduction in mortality. There were 3 small randomized trials that suggested benefit. We did a 2,000 patient trial that showed absolutely no benefit. Therapeutic hypothermia, again, I felt really strongly about that. I had, great anecdotal evidence of patients that shouldn't have done well that did well. And when we really scrutinized them and did them, there was no benefit. So, when I believe strongly about a therapy and there's a clinical trial going on, I think we all have the responsibility as clinicians and stewards of the resources that we provide to put our patients in. I didn't put up the slides on it now. MCS is a great question. So we use MCS much more sparingly in Canada than in the United States. And I've had a lot of my fellows go down to the United States and train in the United States, and they're just like, Impella is going to everyone. One of my intervention fellows was saying, patient is hypotensive in the cath lab for 30 minutes, they end up with an Impella. And so of course those patients do really well, right? So in an observational data set, it looks like mortality is dropping. Well, the best survival curve for any therapy is the one that the patient doesn't need. And so all I can say to you is, we have to design trials that try to enroll the patients that we're treating. We need pragmatic clinical trials. And I think clinicians need to do the right thing when clinical trials are going on and enroll the patients that they would believe the therapy to be beneficial in. You know, a little bit too, I think regulatory wise, we have to do a better job of not approving therapies that don't have a solid foundation of benefit. Because once the cat's out of the bag, it's really hard to put it back in. You know, one of the best examples in the field I work in is left atrial appendage occluders. You know, they've been approved, and it's really hard. I was enrolling in ASAP2, which is contraindicated patients, and patients just refused to be enrolled because they knew they could get the device whether or not they were in the trial. And so, you know, all of that to say, I think, you know, clinicians need to do a good job by putting patients into trials so we get good answers and we know what to do. Regulatory agents need to do a better job of not approving therapies that don't have good RCT data, and clinical trialists need to do a good job of designing pragmatic trials. So, you know, not trials that teach us how to treat 5% of our patients, but that teach us how to treat the, you know, the population that we treat on a regular basis, so that we get that data.
Yeah, thank you so much. Does anybody else have a question for Dr. Hibbert? I guess while some of my colleagues may be thinking of what they might like to ask you, I have a question, but I'm going to kind of take it from a different perspective from Dr. Ahmad. So I'm interested in the educational side and the program that you've put together there to train your fellows or your residents in becoming clinical researchers like this. And just to understand, like, I guess, what kind of institutional support have you needed for that? How has that affected clinical rotations and manpower staffing on the units? And I guess, what size of a training program do you have in order to be able to accommodate something like that, where they get that much, I guess, is it protected research time, or they're doing research?
Yeah. So those are great questions. So, I mean, you know, this would not be possible with, so Mike Froschel is kind of our lead on education. He's our program director for cardiology, and he is, you know, unbelievably supportive of this program. So, you know, in terms of things that we've had to do or arrange to provide this. So first, you know, while all the C1s are off doing their research, the C2s and C3s are carrying the clinical workload. So that's a scheduling issue. I mean, everyone needs to provide their service. So, you know, that's just a little bit of scheduling gymnastics to make sure that these trainees have their protected time. In terms of institutional support, so if we have a trainee who has demonstrated excellence in research and has a commitment to training and research, we will provide funding for their additional years of training. So we provide salary support, and, you know, and that's somewhere in the range of $50,000 to $70,000 for them to take that year off and train. So our cardiology group and our institution has provided that financial support to allow those trainees to have fully dedicated research training time. And, you know, the funny thing is, they always step up and offer to provide that financial support. And we are almost always able to cobble that back with, you know, CIHR support for funding or various scholarships to provide the support. And again, as I demonstrated to you, these trainees produce, you know, outstanding impact publications. So, you know, those investments have always looked really good, because they always end up being, you know, we always have to say, yeah, we're going to provide them with the support, and then they go and get scholarships to support themselves. And then, of course, we have outstanding academic output. So, you know, on a dollar invested standpoint, that's been really good. And then lastly, it's developing a culture. So, you know, for example, for DoReMi 2, what we're doing at our institute, every single trainee is on the trial log. They all have their GCP and their TCPS2, and they can all enroll in the trial. And so, you know, it enables us to run these clinical trials in an extremely cost-effective manner. And so creating that culture, it takes time. You know, it's not something that you can turn on in the next year, it's up and running. But once everyone realizes, you know, I'm enrolling in someone's trial, they're enrolling in mine, and people realize that they get the academic output that they get, you know, people are really keen to enroll in these trials. And we've had great success at running very, you know, relatively large clinical trials on shoestring budgets. And so, you know, it's advantageous to everyone. So you absolutely need the support of whoever's directing your training. And it's helpful to have support of administration. Although I would argue what we've demonstrated is that this is, you know, essentially a cost neutral endeavor once you look at what the outputs are at the back end. But there absolutely is a commitment. So I'll ask a question to the group. Is there anyone that would not feel comfortable randomizing their shock patient to placebo in something like DoReMi 2? Because it's interesting, when we proposed that, you know, the ethics board looked at us like we had three eyes. And you know, it took a few rounds of going back and forth. And actually in the reviews that we got from New England, you know, one of the things people said, which is actually a fair criticism, is, you know, you might be comparing two therapies that increase harm because you don't even have a placebo-controlled trial to demonstrate that it's beneficial. So both therapies could just increase harm. So I have a whole bunch of world experts in heart failure here. Do you think it's reasonable? So I didn't show the protocol, but it's just for 12 hours. It's for the first 12 hours of resuscitation. And there are bailouts, obviously, if the patient is going onto 2 vasopressors, if their lactate continues to climb after 6 hours, or they go into MCS or have a cardiac arrest, they bail out to open label. But, you know, do you think it's reasonable to randomize patients to placebo?
Ben, I can tell you there's a huge amount of variation within at least, you know, every heart failure group that I've been involved in. You know, there's a big spectrum, and it really annoys the CCU nurses because we, you know, rotate through, and has, at least, you know, my bias is that probably the only thing that matters is blood pressure and making sure that you're making urine. Like the fine tuning of, you know, hemodynamics based on Swan-Ganz numbers probably doesn't do anything. But, you know, that's kind of my, so as long as if the patient's blood pressure is 50 and you don't bring it up, then they'll probably die. But as long as you can get, you know, perfusion pressures and to the kidneys and using whatever means necessary, I think you're probably fine. But I think there'll be a lot of variability in the answers you're going to get.
Yeah, it's interesting. I was on call last week for CCU. We had 4 shock patients come in overnight. And now because I'm very aware of it and conscious of it, I actually didn't reach for inotropes right away, where maybe, you know, 18 months ago, 18 months ago, I would have randomized them in DoReMi, but I didn't reach for inotropes right away. And 2 of the patients got better, you know, with a little bit of norepi, some diuresis, and 2 of the patients didn't. And I ended up, you know, initiating inotropes 4 hours after because they continued to deteriorate. So it's an interesting question. Like, I don't know what number of these patients require them early. And it is, like I said, there's definitely arrhythmogenicity. And once those patients arrest, you know, shocking an EF of 25% because they developed VT, it's hard to get those patients back. So the reality is I don't know the answer. I suspect there's going to be a lot, and this is kind of what you were alluding to. I think there's going to be a lot of strong feelings about it, even though there's not a lot of good data. And so, you know, I'm hopeful that we can get centers enrolling that enroll their patients liberally, because I'd love to have the answer to that question.
Mike, maybe you could be the Yale person for the study.
Well, thank you for recommending me and giving me more work to do. I appreciate that. So, no, just in all seriousness, I'm sitting here with one of our fellows, and when we saw that you were randomizing a group, you know, onto inotropes versus none, we both did look at each other like that as well. Like, it's this is but it's a great novel idea, you know, and it is something that we've never. Yeah, I mean, we don't have a good answer for it, so I'd be really excited to see what you find out there.
And what I always say is, you know, if the benefit is overwhelming, because it's funny, because, you know, some people, again, I talk to some ICU docs and they say, yeah, you don't need them. You know, it's only a select number of patients that fail early resuscitation. And some people feel like it's a first line must have medication. And, you know, I don't know the answer, and I'd be interested. And I think it's particularly important in the context of MCS. You know, if we find that you really don't need inotropes routinely up front, maybe the answer is patients need mechanical circulatory support up front. You know, rather than I can tell you in Canada, our approach is like drugs to the end. And only when patients are absolutely failing everything do we go to MCS. And so, that might not be the right answer either. So I think it's really important to know, especially as we have more options to kind of support these patients, about what we should be reaching for and when.
Yeah, no, that's going to be an incredible trial. I'm really excited to see what you find out. Anybody else out there have a question for Dr. Hibbert before we let him go and wrap up for today? Well, if not, thank you so much again, Dr. Hibbert, for joining us today. If you are ever, in all honesty, looking for a site to participate in some of these things, I'm sure we'd have individuals, within our group that would be excited to get involved. So please, feel free to reach out to us. That'd be wonderful. And I know we'd have a lot of trainees that would likely be excited about getting involved in this as well, our fellows. So thank you so much again, and hopefully we get to see you again sometime in the future.
Perfect. Thank you very much for the invitation, and we will absolutely be reaching out to give you some more work.
All right, sounds good. All right.
Cheers. All right, bye-bye.